So I will turn things over to Dr. Najafian for, once again, our excellent renal pathology colleagues teaching that they do monthly. So welcome, Bazad and colleagues.
Okay, good morning. Thank you very much, Matt. Hi, everybody. I hope that you can hear me well, and I trust that you can see my screen well, correct?
Yep, it looks good. You're not on full screen slides, but
yes, yeah, I will go on full screen slide. Thanks again for the opportunity to do another biopsy conference at the RGR. So we have two interesting cases, each with more than one biopsy. So it's like a longitudinal story. And both of them are going to be, the clinical part are going to be presented by Iris. And I know that she may have to leave a little earlier. So without any further waiting, let's just start. And in the meantime, please, whenever you have comments, you come up with the diagnosis and things, just keep typing them in the chat box, and I will do my best to basically keep an eye on the chat box. Okay.
And Iris? Just FYI, you're on the presenter view, so I don't know if you want to switch your...
That's actually, Bazad is actually DJing the slides. I sent over my slides to him.
Okay, yes, yeah. So yeah, are you good with this, Iris?
I think it's in the, you have it on the speaker presenter view, Bazad. I mean, I'm okay with it, but it's not in the full...
Bazad, just go up to display settings. Oh.
Display settings. So this is
up at the top.
Okay.
Which presenter and slideshow.
All right. Okay. Good now?
Looks good.
All right. Let's go.
All right. I'm happy to start. Let me just, okay. You guys can hear me okay?
Yes.
All right, good. Yeah, so our first case, our patient is a 27 years old female. She has history of ESRD, secondary to obesity-associated FSGS. Just a little bit of context. I think it was she was around 15 years old when this was diagnosed. She weighed around 320 pounds at that time. She received a gastric a sleeve gastrectomy prior to being referred, when she was 21 years old, prior to being referred for transplantation. And she's lost the weight and received a deceased donor renal transplant this year from a young brain dead donor. In terms of her induction immunosuppression, she's not sensitized. Her CPRA is 0%. So she received what we call a standard dose ATG, which is at 3 milligrams per kilogram. In terms of her infectious disease risk or status, she's CMV recipient positive, donor negative. We label this as intermediate risk. Her EBV status, she's EBV positive. Next. As for her course, she did well. Immediate post-transplant, her renal allograft functioned well. And at post-transplant day 4, she was discharged from the hospital with an excellent creatinine of 1.12 milligrams per deciliter. The following day, I saw her for her first post-transplant clinic visit. She was doing okay, tired, being home less than 24 hours. Her creatinine that time was 1.06. The following day after that, she called the nurse coordinator, and this was at post-transplant day 6, that she has some nasal congestion and anosmia. She was advised to get the COVID PCR test. And I think one of the fellows got called over the weekend about this. I think Karen got called, and she called that her test was positive. So we arranged immediately for a monoclonal antibody. So she received the casirivimab and imdevimab or Regencov monoclonal antibody. on post-transplant day 10. Her creatinine remained at 1.02 at that time. So her next follow-up visit with me was via televisit at post-op day 12. Her creatinine remained stable. During that visit, she complained of worsening shortness of breath. Her oxygen saturation was still greater than 90%. She did mention occasional loose stool. Because of her seemingly worsening COVID infection, her loose stool, and also the MPA level being 10, I decided to reduce her mycophenolate from 720 milligrams twice a day down to 360 milligrams twice a day. Notably, during that visit, her tacrolimus was elevated at 13, so we down titrated that. And I planned to see her 4 days later. However, I was not able to see her 4 days later because she called in that she had reduced urine output. She mentioned that her loose stool became more of diarrhea, and she's had that for 1 to 2 days. During the evaluation for that, she was found to be C. diff positive. Her creatinine notably, can we go back? Yeah. Her creatinine notably was 3.58. And 4 days ago, just remember, it was just 1.08 milligrams per deciliter. Next. So this is just the highlighted labs from her ER visit and admission on the first day. Her urinalysis showed 1+ protein, 1+ RBC, negative white blood cell. Her urine protein to creatinine ratio is 0.5 gram per gram. She has negative BK and has negative DSA. There was mention that maybe it was low level DP4 at 200. Just of note, a positive MFI would be around 2,500. A weak one would be between, less than 2,500. Imaging that day with an ultrasound showed no anatomic or vascular abnormalities, but basically the imaging was suggestive of an intraparenchymal process. Next. I'm just flashing her labs, but I already highlighted the ones on the previous slide, the main highlights. I think there was a question in the chat that popped up. Should I address the questions now? Is it okay to address the questions now, Bazad?
Yeah, sure.
So Ian asked, Iris, why was she given COVID monoclonal antibodies with negative COVID? She had a positive COVID test.
Yeah.
Yeah.
And Abal is asking, did she have evidence of TMA clinically?
No, in terms of her blood cell counts, if we can flash the complete one. She did not have thrombocytopenia, no change in her hemoglobin on that date of presentation.
Okay. And day 18?
Yeah, so despite giving her good amount of IV fluids, her C. diff being treated by PO vancomycin, her creatinine continued to increase at the level of 4.79. So she received a biopsy, care of Dr. Chris Blosser. Any other questions about this patient's case?
So early post-transplant, COVID positive, negative DSA. What are we expecting to see? What do you think? Okay, so let's look at the biopsy. So this is the biopsy that was taken at the time point that Iris mentioned. So this is the biopsy core. As you can see at low magnification, I mean, shortly after transplantation relatively, so not much chronic injury, but on this mass and trichrome stain, you can recognize that some areas, they have inflammation, some areas they have they have edema. So there were 6 to 12 glomeruli, all of them were patent. The dominant finding in the biopsy was presence of diffuse interstitial inflammation throughout the biopsy core. In some areas, the inflammation was more severe compared to other areas. Now, this inflammation was predominantly lymphoplasmacytic, was associated with prominent and frequent tubulitis. And for new fellows, tubulitis, when we mean there are lymphocytes predominantly in the epithelial lining. And focally, also, this was associated with severe tubulitis, what by Banff scoring system, we call it T3. And that's because, like in this instance, we have breakage of the tubular basal membrane and presence of numerous lymphocytes in the tubular profile. Also, interestingly, in this biopsy, we had neutrophils. So again, the dominant infiltration was lymphoplasmacytic, but we had areas with more neutrophils as well. So looking at the peritubular capillaries, they were a little bit basically difficult to find. There was a lot of interstitial edema and inflammation, but where we were finding them, those peritubular capillaries were mostly clean. Although in some areas, such as in this one, we had focal peritubular capillaritis, or in areas where there was significant interstitial inflammation, active inflammation, peritubular capillaritis was present. But probably not reaching the threshold for significant peritubular capillaritis by Banff criteria. So in other areas, as I said, the dominant picture was severe interstitial inflammation with frequent instances of tubulitis. Looking at the glomeruli, now for microvascular inflammation, we say peritubular capillaritis and glomerulitis. Basically, there was no glomerulitis in the glomeruli. However, there was a very peculiar finding in the glomeruli, and that was presence of what one could call it Bowman's capsulitis, or presence of inflammatory influx in the parietal epithelial cell lining, or maybe the extension of tubular epithelial cells that are coming into the Bowman's space, creating a picture resembling a crescent, but with many inflammatory cells. That was a relatively common finding. And also, it was very interestingly associated with breakage of Bowman's capsule basal membrane. You follow the Bowman's capsule basal membrane, you see that it stops here, and in this side stops here. And basically, the inflammation in the interstitium is coming in. There was no obvious glomerular basal membrane break or fibrin or necrosis. So this was interpreted as an extension of the interstitial inflammation, the same process as rejection rather than a crescentic process. But as I mentioned, it was quite prominent. Many glomeruli were showing the same findings, similar to crescents with breakage of the Bowman's capsule basal membrane. Very peculiar finding, not a typical finding that we see in day-to-day transplant biopsy examination. This sample was not a rich sample in terms of arteries. So this was the only partial interlocular artery that was present there, maybe an adhering lymphocyte, but other than that, no vascular rejection, no diagnostic vascular rejection. In arterioles, however, focally in the arterioles, we were observing that there's endothelial swelling with adhering lymphocytes, but this was not diagnostic vascular rejection. This is not diagnostic endotheliitis. Even if there was diagnostic endotheliitis in arterioles, we do not know the significance of it as yet. And by immunofluorescent, basically, immunofluorescent findings were negative, including C4D. And as we heard from Iris, basically DSA was negative. Okay, question that whether basically these findings could be attributed or partially attributed to the COVID infection or not. So this is the IHC staining for SARS-CoV-2 spike protein S2. I put the positive control staining from long autopsy specimen, and you can see the expression is brown. And this is the case, our biopsy, and as you can see, there's no specific staining. I mean, there is some like nuclear staining that is non-specific. So this biopsy was interpreted as acute cellular rejection of moderate histologic severity and focal glomerular crescent-like lesions that are likely related to the rejection process, with a comment that indeed per studies that have been out in kidney allograft biopsies after COVID-19, we see an increased basically incidence of rejection in cases of like about 45% in this study that was published in AJT in the August. Within a month of positive PCR for SARS-CoV-2, there had been rejection. 3 of those get treated of 11, about a third of them actually, I mean, did not have reduced immunosuppression. So it could have been attributed to either enhanced alloreactive response or reduced immunosuppression. Iris?
So there are some questions in the chat. So Abal asked, did COVID trigger cellular rejection, molecular mimicry? I guess I'll send that off to the rest of the group, that question in terms of the folks' thought regarding it, whether or not COVID triggered cellular rejection or molecular mimicry.
Yeah, I don't think that it is known, but I mean, hypothetically increasing the alloreactivity due to COVID rejection and cytokine storm is basically one of the hypotheses behind that, besides reducing immunosuppression. Anybody else wants to make a comment? Okay.
Yeah. And I think Laura also asked was, what was the patient's COVID? So the patient is unvaccinated. So she was not vaccinated. She tested negative. So we test all the patients when they get called in for an offer. She was negative for COVID when she was called in for the offer. Okay. So after that biopsy, there were some discussions between all teams that included transplant nephrology, transplant surgery, and transplant infectious disease. After discussing with Dr. LeMay and Chris Blosser, we were planning to give the patient ATG. And our idea is similar to what Bazad mentioned. We're thinking that the patient maybe, in the cytokine storm, bit of the COVID pathophysiology. Anyway, so I discussed with the patient the high risk of receiving ATG. That was, I think, Thursday evening after we discussed it in biopsy conference. She agreed to move forward with ATG, and we said, we'll give it to you the following day. What you're seeing here, so I'm just putting the arrows on the times that we biopsied. The first red arrow, oh, okay, there you go. Thank you, Basad. Is when we did the biopsy and when we did an initial treatment. So overnight, she received a dose of methylprednisolone, no ATG yet. And the following day, her creatinine, notable improvement the following day. We decided to hold off ATG for that day and wait another day. And as you can see, in terms of the reduction, improvement of creatinine the following days with the use of methylprednisolone. The patient did not receive ATG for the moderate cellular rejection that she has. And on discharge, she was discharged with a creatinine at 2.1. And she was discharged on high dose oral steroids. And as you can see, it continued to improve with a creatinine of 0.8 to 1 on her subsequent clinic visits with me. So the decision to continue on with without ATG was because she was relatively, proximal to her diagnosis of COVID. Her symptoms were improving. Of note, we did ask lab medicine to check for her COVID PCR, and she was still positive. I think it was 29 cycle times. So whether, how to interpret that was a little tricky, mainly because they measure the nucleic acid, and whether or not it has replication capacity, we did not know. But anyway, we decided to hold off ATG and rebiopsy her. So I waited about 3 to 4 weeks after the initial biopsy to rebiopsy her. And that's the second arrow when her creatinine was around 0.9.
Okay, so let's look at the second biopsy a month later. Was treatment working or not? Or are we seeing new lesions? So let's look at the biopsy at low magnification. This is what you see. I mean, still, I would say that not substantial chronicity, maybe a little bit more blue in the mass and trichrome stain. Just a little bit, not much. And even at this low magnification, still we can recognize that there are areas that they have significant inflammation, but also there are areas that maybe they don't. And we'll go at higher magnification and we'll take a look. So interestingly, the pattern of interstitial inflammation in the second biopsy was more patchy. So in some areas, we had more dense interstitial inflammation. In some other areas, we had more interstitial edema, as we typically see after response to treatment for acute cellular rejection. However, one noticeable change was that this time peritubular capillaritis was quite prominent. So as you can see, I'm showing multiple peritubular capillaries that they are dilated, and there is significant influx of leukocytes in those. This is present in an area with interstitial inflammation, but also in other areas that interstitial inflammation is not that prominent. Still, we see that peritubular capillaritis is present and prominent. And as I said, interstitial inflammation was more patchy. There were some areas where basically significant interstitial inflammation was only barely present or was absent. How about the glomeruli? I told you about peritubular capillaritis. So whenever we see that, we think microvascular inflammation, antibody-mediated rejection. Did we have glomerulitis? We did not. So there was no glomerulitis in any of the glomeruli. It was a very good sample. I showed you that in the first biopsy, we had that, I don't know, Bowman's capsulitis or presence of interstitial inflammatory cells significantly in the parietal epithelial cells or tubular epithelial cells covering the Bowman's capsule. In this one, that finding was absent, or it was super mild and present in some of the glomeruli. Going back to this, I mean, what could question that some of these cells may be lymphocytes, but indeed, none of them were showing those crescent-like lesions. Something that was very interesting to me was that having significant number of glomeruli showing Bowman's capsule disruption, in this second biopsy, I did not find even one glomerulus showing segmental scarring or something that shows an evidence. So it was like that there was some remodeling going on. We don't know. Interstitial inflammation, tubulitis was still present, but was way less frequent. However, focally, still we had severe tubulitis, equivalent to T3 by Banff criteria. So again, this is a tubular profile. As you can see, there are multiple lymphocytes in that, but also we have a breakage in the tubular basement membrane with significant infiltration by lymphocytes. So this would be equivalent to focal severe tubulitis. How about vascular rejection? In the prior biopsy, I told you that that was not a very rich sample. There was only one partial interlobular artery. This one was a little bit better. We had more than 2 interlobular arteries, and one of them, besides endothelial swelling, indeed had endotheliitis. You see that there is a lymphocyte inside the epithelial lining, diagnostic for acute vascular rejection. Immunofluorescence, again, was negative. C4d was negative. However, since we had prominent peritubular capillaritis, we also did immunohistochemistry, immunoperoxidase staining for C4d to show you the control. This is how we expect in the positive cases to see peritubular capillaries showing endothelial pattern of staining for C4d brightly. And in this one, which is our case, that pattern was pretty much absent, although we had some mainly plasma staining in the peritubular capillary. So no definitive staining, positive staining for C4d by immunoperoxidase either. So this biopsy, in summary, was showing acute vascular rejection consistent with band type 2A, and there was focal prominent peritubular capillaritis. However, given that there was no glomerulitis and C4d was negative, we were not able to establish a diagnosis of antibody-mediated rejection. Compared to the prior biopsy, the inflammation was reduced, but still was present. Okay, Iris.
So even when her creatinine was already improved, and even if the biopsy seemingly looks improved compared to before, it did still show activity. She had a DSA measured at this time. Compared to before when it was reading negative, there's a little bit increase to 900 MFI. So we decided to treat her with what she would have gotten initially with ATG. And she is very agreeable to getting the COVID vaccine after 1 to 3 months post the ATG dose.
Okay, questions, comments before moving to the second case? Question.
I'd like to make a pathology comment, if I may, Azad. And that is one of the pearls I think I've had, which now may be slightly tarnished, that I've carried about crescentic glomerulonephridities, when we see them, is that when we see breaks in Bowman's capsules, they are irreparable, and that glomerulus is destined to go on to scarring. And this is the first time where I've seen absolute evidence that that pearl may not be a pearl, maybe just a shiny stone, and is inaccurate, that there is the potential to repair glomeruli with breaks in Bowman's capsules. Absolutely extraordinary from a pathology standpoint.
I totally agree with you. So in line with what you're saying and what we know from the prior studies, I mean, both T3, breakage of the tubular base membrane, had been shown by prior studies that is associated with accelerated scarring in the biopsies, in the transplant biopsies. Also, I mean, for Bowman's capsulitis, let's say, there is also a paper that they indicated that none of the cases that they showed or described was similar to this case, but they indicated that that was associated with worse outcome as well. I totally agree with you, and I was quite amazed in the second biopsy with both first and second biopsy had many glomeruli to see that, okay, I did not find any evidence for scarring, even like periglomerular scarring or fibrosis. That was very, very interesting to me.
I actually think you should report it.
I totally agree. We should report that. Okay.
Can I ask a quick question?
Azad, one other question or comment. Again, going back to the sort of periglomerular inflammation. So do you think the cells are being drawn to the glomerulus by some cytokines or glomerular injury that's not detected, or is this sort of breakage into the proximal tubule and cells coming up the proximal tubule, forming those sort of inflammatory pseudocrescents?
So both these processes may have been involved, but the fact that the inflammation in the glomeruli was pretty frequent. I want to say that most glomeruli had this feature rather than, didn't. So it was even more prominent than tubulitis. Now, in this case, there was something else which was different as well, and those were presence of neutrophils. And we had neutrophils both in the Bowman's capsule, Bowman's space, where we had these crescent-like lesions, as well as in the tubulitis. But if I want to compare that, okay, how many tubular profiles were showing tubulitis, how many glomeruli were showing this lesion, my feeling was that there are more glomeruli with this lesion compared to tubules with severe tubulitis. So I think that there was something peculiar, but of course, I mean, I can only give you numbers that I can't prove. Well, there are studies, non-clinical studies that you perhaps recall that in early rejection, one of the areas that you can see the inflammation is periglomerular region, and there was this reasoning that maybe basically there are immunologic reasons for that. Whether that is involved in this case or not, I don't know. Okay. There are a few more comments. So Iris, did you guys check for IL-6 or ferritin? A question from below.
Yeah.
Oh, and you answered that. Okay, you answered the question basically. Sorry.
I think, but Sarah has another question. Let's see. Iris, is the 1 to 3 month period before vaccination based on duration of action or of ATG, or extrapolated from other vaccine studies? So actually, that recommendation is based on vaccination practices on, like, for example, flu vaccine, because it's important to get the flu vaccine. So ID usually recommends 1 to 3 months after receiving a lymphocyte depleting agent or rituximab. Now, the tricky part is in terms of duration of action of ATG, it can last longer than that time frame, but it's just a matter of benefit risk. We would rather the patients be covered with flu, and in this case, COVID vaccine sooner, and not wait for when the medication is completely out of their system.
Got it. Thanks, Iris. There's some recent oncology trials, and the rituximab effect is going on up to a year.
Yeah.
So I was just wondering.
Yes, that's correct. I think Chris Blosser forwarded that email to us. So yeah, yeah. Thank you. Yeah.
Okay, so if that's okay, let's move to the second case, because that is also a fabulous one. So Iris, I have included biopsies for each piece of clinical history is within the clinical lines that you've provided. So just, you can feel free to go ahead with the slides.
Okay. Yeah. And just feel free to talk about the biopsy as you have arranged them. Thank you. Okay. So our second case, our patient is a 27 years old male. He has history of ESRD secondary to C3GN. It was first noted back in 2016. He presented with nephrotic syndrome. He had proteinuria of 9 grams. His creatinine at that time was around 1.3. He received a biopsy, and I think Bazad will show that. That shows immune complex.
Okay, so I will go over the biopsy. Sorry, I will go over the finding, but just to give the audience a feeling about how the patient presented at that time. At that time, of course, we didn't know what the biopsy is going to show, right? So presented with nephrotic ring proteinuria, low C3, negative ANA titers, negative ANCA, negative ASO, and negative SPEP. And cryo was pending at the time of biopsy. So let me go over this biopsy, and then we'll go over the rest of the story. So this is the biopsy core, and on trichrome stain, as you can see, there are areas with chronic injury. They look blue. Also, the glomeruli, they look full, and they have a lot of blue in them that usually we do not like to see. On Jones, methenamine silver, where we can see the extracellular matrix and basement membranes well, what we can see is that there is an accentuation of the glomerular lobular pattern in all of the glomeruli. And this is a pattern that we call it membranoproliferative. And when there is influx of inflammatory cells, it's membranoproliferative glomerulonephritis. So what are the other features that we see in membranoproliferative glomerulonephritis, or MPGN for the fellows? So we have endocapillary hypercellularity, so that accentuation of the lobular pattern with influx of cells, endothelial swelling, and the normal architecture is gone. We have mesangial hypercellularity. You know that more than 3 nuclei when we see in the mesangial region. We have glomerular basement membrane duplication, which is very apparent in this case. And we have the position of this eosinophilic material, most consistent with deposits. In this case, also there were a couple of glomeruli that they had collection of epithelial cells in the Bowman's space, raising concern for crescents. But no fibrin or glomerular basement membrane breaks were observed. Also, some glomeruli were showing segmental sclerosis, more prominent in this glomerulus and here as well. So the scarring was also going on in the glomeruli. Okay, we have an MPGN pattern. There is some scarring associated with that, both in the tubular interstitium as well as in the glomeruli. Okay, MPGN. What is the cause for that? Of course, we need to do immunofluorescence as well as electron microscopy. So what did immunofluorescence show us in the first biopsy? This is IgG. There was quite a strong IgG staining, IgG deposition in the mesangium, as well as segmentally in the peripheral capillary wall, but predominant in the mesangial regions, and also in the Bowman's capsule basement membrane. The IgG deposition was not limited to glomeruli, but was also present in the tubular basement membrane. So granular staining of IgG in the tubular basement membrane, also a little bit in the vascular wall. This is an interlobular artery, and as you can see, there is a little bit of IgG deposition. Was IgG the only immunoreactant? There was a little bit of IgM, traced to 1+, so IgG was 3+, like traced to 1+ IgM, traced maybe focal and segmental pattern, C1q, kind of similar to IgM as well. C3 was quite strong. It was called less strong compared to IgG. It was called 2+. So IgG 3+, C3 strong, but still lesser than IgG. Is it monotypical IgG? It was not. Kappa and lambda, they were both positive, like traced to 1+, not very impressive, but nevertheless, they were both positive. Okay, we had a lot of deposits. By light microscopy, you saw those. By immunofluorescence, you saw those. But interestingly, by electron microscopy, when we look at these biopsies, we see the accentuation of a lobular pattern, influx of leukocytes. As you see, these are neutrophils lining up in the capillaries very nicely. But the deposits were interestingly very peculiar in terms of that some of them were ill-defined, they were not much electron dense. In many areas, indeed, they were not electron dense at all, kind of granular. And in some areas, you get a feeling that, okay, there is something also, I mean, like a kind of dense deposition along the glomerular basement membranes, very segmentally. Rarely, we had subepithelial humps. Now, notice that the density of this hump, similar to those deposits, is not that great. You have to pay attention. It can be confused with just like a fold of the glomerular basement membrane. And you see the podocytes over that show effacement. And inside the mesangial or capillaries, difficult to tell what is what in terms of structures. We had an influx of neutrophils, we had influx of macrophages, and we had a lot of those deposits that they are not that electron dense. So we have an MPGN pattern. We have significant deposition by immunofluorescence, and we have deposits by electron microscopy in the mesangial subendothelial regions. We have rare subepithelial humps, but interestingly, I mean, these deposits are not like the typical dense and well-defined immune type deposits in that kind of sense. So this is a capillary loop with significant endothelial swelling, and you see kind of these vaguely electron dense deposits again. These are better, discrete deposits in the mesangial areas. When we go at higher magnifications, they become even less impressive. They look more kind of granular. So with those findings, remember, there was strong IgG, C3 was a little bit less than that. The biopsy was signed out as MPGN, membranous proliferative glomerulonephritis, immune complex mediated, with a list of differentials, so that it can be idiopathic or it can be secondary. Secondary to what? Secondary to, for example, infections. We had the subepithelial humps, right? We had some neutrophils. We have C3 was low. So all of those, they basically support maybe there is an infection, but there was no infection. Clinically, there was no obvious infection. It could be secondary to cancers, could be secondary to autoimmune conditions. We had extraglomerular deposits. We had tubular basement membrane. We had vascular wall deposits, looking kind of like lupus. We had some C1q, some IgM. We had no IgA. We had no tubular reticular aggregates. Just some findings that pushes us to infection, some findings that pushes us to an autoimmune lupus-like condition, but none of them completely matches. ANA was negative. Anti-dsDNA at that time was negative. So that's why basically the biopsy is signed out as MPGN immune complex mediated. Okay, so Iris, I included just this line. I don't know if you want to say more about this at 2018, because then I'm going to show another biopsy.
Yeah, I was just going to mention, in 2016, after that immune complex biopsy, he was treated with Cellcept steroids and rituximab. Despite that treatment, though, as you guys remember, his creatinine was 1.3. It increased that year to 2, and then 2017, I think his creatinine was already in the 3s. So pretty sort of increased creatinine year by year. And in 2018, and then I'm just assuming based on the records, and they did a repeat biopsy, and Behzad will show that. I'm assuming because of worsening creatinine from 3 accelerated to 5 milligrams per deciliter. At this time point, in terms of other labs, he had a low C3, he had a positive ANA and anti-double-stranded DNA, and they reperformed the biopsy for an elevated, even more elevated creatinine.
Yes. And this is that biopsy. Unfortunately, shows significant progression of chronic injury. As you can see by Masson trigram, there is a lot more blue in the interstitium, at least moderate tubular interstitial fibrosis. How about the glomeruli? We had a good glomerular sample in the prior biopsy, in this biopsy as well. In the prior one, although there was significant involvement by MPGN, basically none of them were globally sclerosed. In this one, 20 to 30% of them were globally sclerosed. About 20% of them were showing segmental scarring as well. Okay, MPGN was persistent. As you can see, the accentuation of the lobular pattern, it looks now even more deposits. I mean, they are becoming really nodular. The glomeruli are becoming obliterated by this eosinophilic material, representing the deposits, segmental scarring, tubular interstitial fibrosis. So the disease process is progressing. You can see that the MPGN is one of the differential diagnoses for nodular glomerulosclerosis, right? But it's more cellular than that, and you can see a good example of that. I mean, there are huge nodules with many cells, mesangial hypercellularity, endocapillary hypercellularity. Basically, I mean, you can't tell where is mesangium, where are the capillaries, except if you see like red blood cells hanging around. Now we're seeing some more findings that may be related to basically progression of the chronic injury and superimposition of the hypertension, severe hypertension, or maybe something else. So for example, I'm showing two small interlobular arteries. One of them here shows mucoid degeneration of intima. That's like the edema in the intima of this interlobular artery. That's a representation of thrombotic microangiopathy somewhere between acute and chronic. We see that commonly in like uncontrolled hypertension, accelerated hypertension. Here is another one, another small interlobular artery with onion skin appearance, representing repetitive injury to the endothelial cells. And, you know, the lumen is almost completely occluded. Again, another manifestation of chronic endothelial injury, thrombotic microangiopathy. You can see that in accelerated hypertension and so on and so forth. Immunofluorescent, it's different. This time it is different. Last time there was a lot of IgG, 3+. This time IgG was quite variable. Some glomeruli, no IgG at all. Some of them, a little IgG. C3 was dominant. So all those deposits that we were seeing looks like they are all C3. This time there was no extraglomerular staining either in the tubular base and membranes of vessels. This is almost all C3 now. No other staining with immunoreactants. Electron microscopy is still remaining on the relatively unimpressive side in terms of electron density of the deposit. So we have a lot of changes in the electron microscopy. We have, you know, mesangial expansion, hypercellularity, MPGN pattern, glomerular base and membrane duplication, and so on and so forth, influx of leukocytes. But when we're looking for the deposits, there are these ill-defined deposits that actually, I mean, you know, that's one of the features of C3 deposits. But I would have expected to see a lot more of these. And they are not that electron dense in this particular case. And again, when you go on higher magnification, they become even less obvious. They turn out to be more kind of granular. So this time, we called it C3, the findings are consistent with C3GN. Also, there was a lot of inflammation and chronic injury in the interstitium that basically the interpretation was that mainly related to glomerular lesions. And also we had features of onion skinning of arteries and mucoid degeneration, like features of chronic or chronic active thrombotic microangiopathy. Iris?
So after the 2018 biopsy with a label of C3GN, the patient received eculizumab. He had some response, just looking at his creatinine. It went from 5 and was maintained around 2 to 3 for the subsequent years. Ultimately, though, in 2020, he started dialysis. And in 2021, he received a deceased donor renal transplant from a young donor, brain death. Induction, he received standard induction. This patient was not sensitized, so he received around 3.5 milligrams per kilogram. Of note, he also received eculizumab intraoperatively. And just to highlight his infectious disease status, this patient is CMV recipient negative and his donor is positive. So we label him as a high risk for CMV. His EBV status is he's positive for EBV. Next. So his post-transplant course, he did well in terms of allograft function. His creatinine baseline, he had immediate allograft function. Creatinine was 1 to 1.2 milligrams per deciliter. He was continued on revoluzumab, the Ultomiris, which is the longer acting terminal complement inhibitor, similar to eculizumab, but it's given every 8 weeks. One of his complications post-transplant was at 3 months post-transplant, he developed leukopenia. It was attributed to medications. His CMV PCR was negative at that time. That leukopenia lasted for about 4 weeks. We treated it with Neupogen, and for about 1 to 2 weeks, we held the mycophenolate. When I think his ANC went as low as, you can see it down there. I don't have my pointer, but that was, I think, 0.2 or 0.3 with his ANC there. And we held the Bactrim, and as you can see, it improved later on, and we have resumed the mycophenolate and the Bactrim at that time point after improvement. Suzanne has a question. Is that typical to administer eculizumab at time of transplant for a patient like this with borderline factor H deficiency? Yes, so for patients with, in our center, for patients with diagnosis of atypical HUS or C3GN, we do, in consideration of the risk of recurrence, we give patients eculizumab around the time of transplant. So for him, and I have a handful of patients with C3GN diagnoses, my practice is to do sort of like a baseline biopsy to have an idea of how their allograft is looking in case there are some clinical abnormalities or renal decline later down the line. So for this patient, I did my baseline biopsy around 5 months post-transplant. His creatinine at that time was stable at 1 milligram per deciliter. His urinalysis showed generally he would have 1 to 3 plus RBC in the urine, and this has been present even prior to the transplant. His urine protein to creatinine ratio is stable at 0.2 gram per gram. His DSA is negative, and I just put up there his cell-free donor-derived DNA at 3 months and 5 months at 0.29% and 0.51%, which in general is labeled as negative, but as you can see, maybe potentially a little bit increased compared to previous. Next. I'm just flashing his labs, but I already highlighted it on the previous slide. Next.
Okay. Now in the biopsy, in the baseline biopsy, what are we expecting to see? Nothing, normal, rejection, or something else. So this is the time zero. I would like to start with the time zero biopsy in this case, and then show you the baseline biopsy after that. So basically the time zero biopsy was pretty much unremarkable, except that there was some acute tubular injury that commonly we see in time zero biopsies, the renal capsule. You mentioned that the donor was young, right? Do we know the age of the donor? Age, gender?
I don't have the exact age of the donor, but young. And young. I label young, they're around 20s to 30s.
Okay. So 20s to 30s. All right. And we don't know the gender, do we?
I do not recall currently. Yeah, but...
Okay, fair enough. So this is again the time zero biopsy. Looking at the glomeruli, they look fine. They don't show any abnormality. We did immunofluorescence, and that was negative. C40 was negative and everything. Now we move to the 5 months biopsy. So the 5 month biopsy also looking at the mass and trichrome stain. This part on the left, it looks fine. Basically tubules are pretty much back to back. In the other piece, there is very focal increase in fibrosis. Not really that significant, quite mild, with a little bit of inflammation. Again, most of the areas, the tubules look like this, back to back, nice. No significant peritubular capillaritis, maybe a couple leukocytes hanging around here and there. No significant interstitial inflammation, no significant tubulitis, basically no concern of rejection. However, glomeruli by light microscopy were concerning. So looking at this glomerulus compared to this glomerulus, as you can see, look at the Jones and mesangial areas. You can barely see them, and if you see them, they are dark and thin. While in this glomerulus, they are not dark, they are red, pinkish red, a little bit, just a little bit expanded, still no significant hypercellularity probably, but these red deposits are frequently present, and sometimes they are also present in the subendothelial region and associated with early glomerular basement membrane duplication, basically reminding us of a very early stage of the same process that we were seeing in the native kidney. Again, this is another glomerulus. This finding was diffusely present in all the glomeruli. Again, mesangial expansion with deposition of this eosinophilic material. Here we have some hypercellularity as well. And here we have basically deposition in the peripheral capillary wall, something that, you can imagine that if this process progresses, that will end into MPGN. So what are these deposits? Are these made from the same stuff that were in the native kidney? Yes. So there is very strong C3 staining in the glomeruli, in the mesangial regions. I mean, the glomerular tuft is shrunken. It's a little bit difficult, but it looks like at the peripheral capillary walls, we are seeing them as well, at least in some regions, if not all. And I took a picture of C1q just for your comparison. So this is C1q, pretty unremarkable, negative, or at most like 0 to trace, something like that. And there was nothing else. There was no IgG, there was no IgA, there was no IgM, nothing else. C4d was negative. The glomeruli in the transplant biopsy, as I'm showing here, you said that basically the donor was young. We observed some glomerular basement membrane thinning, or thin glomerular basement membranes, in some areas below 200, around 200, some other areas above 200. The average was around, I believe, 220 nanometer. So, which depends on the age, but I mean, that whatever it is, it's a precondition from the donor, and we do not tend to think that that is something significant. But although, I mean, if the donor is very young, then that can indeed put this transplant at another risk, and that would be very significant remodeling of the glomerular basement membranes that was originally described by Tibor Nadasti, and that can be a progressive thing leading to proteinuria and FSGS. I do not know whether that's the case in this. In this case, you said that the donor was like 20 to 30 years. Usually that condition happens when the donors are at very young age. So maybe, I mean, this was a female, maybe this patient, the donor had thin basement membrane or something. Okay, what about the deposits? So the deposits were not really that remarkable, even in the native kidney in terms of electron density. In this one also, still they are shy to show up as electron dense deposits. We only have some vague, ill-defined electron densities in the mesangium, as well as some in the subendothelial region. That's it. they were so few and so basically unremarkable compared to the light microscopy and immunofluorescent that I even, I had some doubt that maybe there wasn't a specimen swab because I was expecting to see more deposits. Although, I mean, given the fact that in the native kidney, the deposits were not that electron dense, one could imagine that in this one, it might have been the case as well. But we double checked, no specimen swab. But even though because of that, we did reprocessing salvage paraffin EM, I was hoping that if we see deposits in here, then I would have more reason to think that there was a specimen swab, which anyway, I mean, we did not see because there was a lot of artifact. As you see, I would say that this salvage paraffin EM was not that successful because, there were, because of the artifact, you can't say that the deposits are there or they are not there. So basically, the biopsy findings are interpreted as recurrent C3GN, and there are multiple studies out that basically they indicate all the same things. C3GN, we know that is associated with very high risk of recurrence post-transplantation, and also, I mean, it's a progressive condition, as you know, and unfortunately, the risk of graft failure is high as well.
So Behzad, I just have a question for those biopsies. With regards to the C3GN recurrence, my understanding on review of those is majority have clinical, derangements already, such as increased creatinine and worsening proteinuria. And it does show more sort of active, with more proliferative lesions. And I think my patient did not have significant sort of proliferative lesions, correct? I just want to.
Yes, because you do baseline biopsies for your practice. You do, these are not this is not like an indication biopsy. They wait more. Every process that is more progressive starts from very mild, and you cut that at earlier stage, which is very good. So there is, aside from that reference that I put there, it's a paper in JSON. There is another series that I think in 2018 published in AJKD, and they reported the recurrence is early as, I think they put 0 months, which I don't know exactly how many days that means. But if you do protocol biopsies, I assume that you can catch them at earlier stages, such as this one.
So in my patient's case, I, of course, continued the ravulizumab for him. And part of my thought was maybe when he was leukopenic and I, held back on the mycophenolate, could that have contributed to it? And the reason why I say that is, as you guys know, in terms of literature, mycophenolate is considered sort of like first line for C3 GN, and there have been reports of maybe when you stop the mycophenolate at 12 months, there can be relapse with patients. So I'm not sure, but anyway, part of my management was to uptitrate the mycophenolate to highest tolerated dose. In addition, ACE and ARBs, of course, for the proteinuria. But like I mentioned, my patient did not have any clinical renal abnormalities currently, but I just want to optimize the status.
Questions, comments?
So I just put one.
Yeah, sure. Yes.
In the chat. So what do you make now of the first biopsy with the prominent IgG, with the discrete tubular basement membrane deposits?
Exactly. I mean, I would think, and I don't know about the transformation. Well, I can't quite explain the transformation, except for that maybe because even at that time we did not have serologies positive for ANA anti-dsDNA, but later on they became positive, I believe with low titers, as I remember from discussions with Dr. Ara. most likely the patient had an underlying condition in a background of C3GN that was aggravated because of that background. And that condition, whether that was a lupus-like condition or an autoimmune condition, or was that in really a subtle infection process, led to that manifestation with the TBM deposit, the vascular wall deposit. We think that more likely and like a lupus-like or autoimmune thing in the beginning, and then perhaps that went into a regression related to the treatment or not. I do not know. But that's the only explanation that I came up with. I don't know if you or others agree or have any other thoughts. But yeah, it is very interesting. Clearly, there were IgG deposits. Clearly, there were TBM deposits. They were all gone. The second one.
Hey, Azad?
Yes.
Did you do a paraffin IF to look for mast deposits? I mean, that first biopsy, as we just discussed, suggests that there might be an antibody response really that's underlying this C3 glomerulopathy. And the question is that something that should be targeted? And is there any evidence to support the fact that there might be some antibody still playing a role in this patient's MPGN?
Yeah, no, we did not do that. I know that like SPEP, UPEP, and free light chain acid, they were all negative. But we did, because of that, we did not do it. I agree that we could do it. I do not have significant hope that would have show up as positive. But because, if you think that it's the same process as the first one, why the deposits, the immunoglobulin, for example, is becoming masked now, a mask antigen. But I can see your logic. And I don't think that there is
evidence that showed up as like a post-infectious with more obvious immunoglobulin that then just really transformed into just more of a standard C3 glomerulopathy. And so, Occam's razor would say that, this is the same thing. And maybe our ability to detect the antibodies that, who knows what they are or what they're directed at in this instance, may change with time. Maybe there's some other factor that's leading to excessive C3 deposition in this patient, but maybe the antibody is sort of a necessary component to the disease process.
Yeah. Do you think that there is value to do it now?
Well, I do.
Okay. Would you do that in the native kidney biopsy or in the transplant, or both?
I don't think you can do it in the transplant anymore, right? Because you said that you reprocessed the paraffin.
We reprocessed part of it. There was a large biopsy course, so I've kept the rest.
I would do it in both. Then.
Yeah, we can do that. Sure.
I agree with Kelly. I think that would be useful for trying to understand what's going on, including if the patient's course does not were not to go well in the future.
Sure, we can do that. Any other comments?
Well, thank you so much, especially to Behzad and Iris for these two fascinating cases today. And of course, always all of our renal pathology colleagues. So thanks to everyone for coming this morning. Just a reminder, next Friday is a faculty meeting, and then we'll resume nephrology grand rounds the following week. Hope everyone has a nice weekend, and take care.
Okay, thanks everybody.